Good evening and welcome to the program. I'm Dr. Margaret Fitzgerald, and I'll be teaching this session tonight on antimicrobial therapy, prescribing and select bacterial, skin and soft tissue infection, as well as GU infection. Thrilled to have you join me this evening. Stephanie Austin is on with us for support. Any questions for her, like about about technical issues and that type of thing, you could put those into the chat for her. And then questions for me, what I would ask you to do is, if you look at your control bar for Zoom, way over to the right, there is a circle that's over the word more with 3 dots in it. A Q&A box in there, and that's where I would like to get questions. And I'm the only one that can see the questions, and I really want to make sure that we can answer your questions. So with that in mind, let's get going here. Again, I'm the founder of Fitzgerald Health Education Associates. My clinical practice has been at an FQHC, Federally Qualified Health Center, in family primary care in a small city about 30 miles north of Lawrence, and with a predominantly African Caribbean community. And it's been a great privilege to practice there for more than 35 years. I've actually practiced literally in the same neighborhood for 35 years. So I've had multiple generations of families come through my exam rooms. I'm on faculty at Case Western Reserve, which is also where I did my doctoral studies. And I work with them on an international nursing leadership project. I sit on the editorial board of a number of different publications, and I'm also a member of the Pharmacy and Therapeutics Committee for a major HMO in Boston, Mass General Brigham Healthcare. And as a matter of fact, we've got a Pharmacy and Therapeutics Committee meeting tomorrow morning at 7:30. I'm the only NP and the only primary care provider on that committee. And that is really, it's such a privileged thing to be able to do. So disclosures: no real or potential conflict of interest to disclose, no experimental or investigational use of drugs or devices will be presented. Off-label use will be identified if, as such, if discussed. I'm not going to be talking about anything off-label here. So upon completion of the learning activity, identifying factors influencing the choice of antimicrobial in the treatment of UTIs and skin and soft tissue infection. Describe the influence of antibiotic resistance in the antibiogram in the choice of a therapeutic agent, and then recognize those teachable moments in antimicrobial therapy for the above mentioned conditions. And the references will be throughout the presentation. Last week's program on bacterial respiratory tract infection, I included a section on that on antimicrobial stewardship. In other words, about not when to prescribe antimicrobials, not when not to prescribe them. And that's when the work that I do with Fitzgerald Health, where I am in front of literally hundreds, if not thousands, of NPs just getting out of school or towards their end of their studies with NP review. One of the things I always try to reinforce to them, and I'm sure that you do as well in your teaching, is it is as important to know when not to do something as it is to know when to do something. And antimicrobial stewardship is key on that. And just a reminder with this, any of the case studies I present, anything along those lines, we are considering these open access, and you could share them with your students. So skin and soft tissue infections, GU infections, particularly, I'm really going to focus in on UTIs. Are the bugs winning? Yeah, it does seem like they are. But is this a new problem? And in late 1920s, Sir Alexander Fleming, seen here in this image, was the first to suggest that the penicillium mold must secrete an antibacterial substance, and then the first to isolate the active substance, which he named penicillin. And you probably have all heard the story that there was a culture plate left out in his lab. Some mold grew on it, and what he realized was around the mold, some of the bacteria was gone, so that there was a ring around, a clear ring where no bacteria grew on the culture medium, where the mold had managed to grow on the culture plate. So pretty interesting. And then, so that was the late 1920s. And now this is 1945, mid 1945. So what do we know? We're in the era of World War II, and towards definitely the end of World War II here. And one of the first wide-scale uses of penicillin was in the military during World War II. And what it did was the use of penicillin had a major impact on reduction on wounds that previously would have been infected, like during World War I, could have been infected, but there was no antimicrobials available. But now World War II, we had penicillin, and the general public started hearing about this, quote, miracle drug. And it was actually one of the first times that the term miracle drug was used in the popular press. So this is Sir Alexander Fleming being interviewed by the New York Times in mid-1945. And this is what he said: the microbes are educated to resist penicillin in a host of penicillin fast, what we would now call penicillin resistant organisms, and bred out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to an infection with a penicillin resistant organism. I hope this evil can be averted. It was the mid 1940s, and we already had resistant pathogens. Because here's the interesting thing is we tend to think of like just good old-fashioned penicillin. Doesn't work on much anymore, does it? No, but it still is the number one antimicrobial for the treatment of bacterial pharyngitis caused by group A beta hemolytic strep. Even though it's not the most commonly prescribed antibiotic for that. And it also works quite well in a lot of dental infections, and there are even select skin and soft tissue infections that it still works in. So it is amazing that in 80 years of penicillin being around, we haven't worn it out yet. But it is pretty narrow in what it works on compared to 80 years ago when it took care of a myriad of different infections. So let's take a look here for a moment at treatment of gonorrhea. And I love this, this ad here. It's an ad on the side of a trash can. It is from the 1940s. And that one of the things is you'll see the ad on the top of there, buy bonds. So it's buying war bonds. And then what I really like about this is that it says penicillin cures gonorrhea in 4 hours. That's my favorite part of that, is it's just gone in 4 hours. Of course it isn't. And what you might not be able to see underneath the word gonorrhea, it says the great crippler and sterilizer. And the reason for that is disseminated gonococcal infection, gonococcal arthritis, was not uncommon because somebody got gonorrhea and there was no antimicrobial available before penicillin to take care of it. The sterilizer, it was recognized that both males and females could be rendered infertile after having gonococcal infection that invaded the upper reproductive tract. So telling people to see your doctor today. So this is, I love this for two things. One is about promoting antimicrobial use and a really fanciful fanciful claim here of curing gonorrhea in 4 hours, but also one of the first direct-to-consumer ads for what we now think of as a prescription drug. All right, so back then, all gonococcal species were sensitive to penicillin, right? They didn't produce beta-lactamase. They didn't do anything fancy. In the 1980s into the 1990s, what happened was penicillin was still being used primarily for gonococcal infection. FYI, this is within my time of being a nurse practitioner, but there was an advisory to add probenecid to it. Probenecid is simply, it doesn't have any antimicrobial properties in and of itself, but what it does was it kept the penicillin from being offloaded, and therefore higher levels of circulating penicillin just made the penicillin hang around longer. And by the way, penicillin for the treatment of gonococcal infection was always given IM. In the early 1990s, we started using ciprofloxacin instead of penicillin because what happened was the penicillin started to produce beta-lactamase, and the beta-lactamase would take the beta-lactam ring in the penicillin molecule, cleave it, and render it not effective against a gonococcal infection. And ciprofloxacin started to be used. Single dose of ciprofloxacin, easy enough to eradicate. In the early 2000s, ciprofloxacin went by the wayside, and we started using ceftriaxone. Why ceftriaxone? Because now we had gonococcal infection that was resistant to ciprofloxacin. And now here's one of the tough parts. Now it's an IM drug. We're back to an IM drug again. That was one of the nice things with Cipro, is just here, take this pill, you're done. Yeah, it was really nice during those days. Ceftriaxone started going to that, but it was 250 milligrams of ceftriaxone as a one-time dose. The gonococcal organism, as long as you've got the right antibiotic, is actually pretty easy to eradicate. Okay, generally single dose therapy. And then 2020, with the last iteration, well, actually the last major update of the STI guidelines from the CDC came actually in 2021. But prior to that, the year ahead, they did an interim advisory and said, 2020, what we have to do is now go to 500 milligrams of ceftriaxone as that one-time dose due to lower dose treatment failure. So when organisms are resistant, they can be resistant from a number of different mechanisms. But what we've got here is one example of penicillin the standard dose wasn't enough. So penicillin with probenecid, and now in essence, you've got high dose penicillin. Oops, produces beta-lactamase, chops the penicillin up. We've got to go over to ciprofloxacin. Whoops, literally within about 10 years, we've got ciprofloxacin-resistant gonococcal infection. We've got to go to ceftriaxone. And 20 years later, whoops, we need a higher dose of ceftriaxone. So sometimes antimicrobial resistance can be overcome with a higher dose of a given medication, like drug-resistant strep pneumo. We can go to just a higher dose of amoxicillin and it will take care of it. But sometimes there is a different mechanism, like the production of an enzyme like beta-lactamase. That means you have to ditch one class of antibiotics and just go to another one, right? So is a culture and sensitivity typically done with gonococcal disease, and that following the spread of gonococcal fluoroquinolone resistance, cephalosporin antibiotics have been recommended as the foundation for the treatment of gonorrhea. So general rule, we don't do a culture and sensitivity with gonococcal infection – because there is an assumption that all of the gonococcal infection out there will be sensitive to high dose ceftriaxone. That's just the way it is. However, what started happening as recently as 2022, and remember it was 2020 that the higher dose ceftriaxone started being recommended for gonococcal disease. This advisory came out from the CDC, and it says if patients persistently test positive for gonorrhea after treatment, whether with or without symptoms, and reinfection has been ruled out, or if disseminated gonococcal infection, in other words, that's systemic gonococcal infection, which can include gonococcal arthritis, has been noted, please consider seeking susceptibility testing for the isolate. Data from this testing helps the CDC monitor for new types of resistance and can provide information for treatment options. So that was only a couple of years ago that advisory came out. However, that said, the drug resistance or ceftriaxone resistant gonococcal disease has not seemed to grow over the last few years, so hopefully it won't. But it's been interesting over the course of my career to see the changes in gonococcal treatment, and this is the reason why. By the way, this is a suspected gonococcal treatment failure consideration form from the CDC. And by the way, with the treatment of gonococcal infection and chlamydial infection, we do a post-treatment retest of them. We're generally not testing for treatment failure. We're testing more for reinfection. That's the main reason behind that. All right. So we get back to an adage, never ask a drug to do something it can't. And the most common reason for antibiotic treatment failure in outpatient care is not resistant organisms, but rather prescribing the wrong drug or the right drug in an insufficient dose. I'll always will say that to folks that I'm teaching who are newer to this is don't be the person who is going and saying, oh, but it says the range of this antibiotic is 250 to 500 milligrams BID. I'm just making up an antibiotic here. Don't be the person that says, oh, I think I'll go on the low end here. No, go to the higher end, because the major reasons for treatment failure in antimicrobial therapy is underdosing. And remember what underdosing will do. Underdosing will take care of the more sensitive isolates and leave behind the more resistant. So go with that higher dose. And in order to prescribe an antimicrobial, of course, you need to know the causative bug so that you can choose the right drug. And evidence-based antimicrobial therapy is based on this principle. So common UTIs, let's start off with talking about this. And what ends up happening with the NP student? For the most part, they're coming from an acute care setting, correct? Medical floor, surgical floor, ICU, the ER, something like that. And they'll say, in the hospital, I see patients with UTIs who are on IV antibiotics. What do I prescribe for outpatient therapy? Okay, well, teachable moment here. In your nurse practitioner practice, which most of them are going to be family or adult general primary care folks, right? So particularly in the outpatient setting, you're going to be seeing people with uncomplicated UTIs. And what is the definition of an uncomplicated UTI? No anatomic variation, intact bladder emptying, predictable pathogens, super predictable with UTI, less risk for resistant pathogen. Now, in their RN practice, especially inpatient, what are they more likely to be seeing? Complicated UTIs. Complicated UTIs, by definition, there will be one or all of these. Urinary tract and anatomic variation, urinary retention, catheter association, And of course, since they're in the hospital, they have a greater risk for resistant pathogens. And when talking about this with students, while this is what I always encourage them to do, while they're in their NP program, I tell them, you have to start conceptualizing yourself as the NP. And so you're not the person who reports off the culture report to the prescribing provider. You're now the prescribing provider, and you need to start thinking like the prescribing provider. So start reading all culture reports. Just do. Correlate the causative pathogens with the antimicrobial class that was prescribed. And I would also say, which I should have put in this slide, start recognizing patterns. That, like with UTIs, you get a lot of gram-negative organisms. With bacterial pneumonia, a lot of times it's a gram-positive organism like Streptococcus pneumoniae or one of the atypical pathogens like Legionella or M. pneumoniae. Start recognizing what bugs cause what diseases. And then start thinking about antimicrobials in classes. With the fluoroquinolones, they all have that floxacin suffix. The cephalosporins either have a CEF or a CEPH prefix. There's hardly any left now, like cephalexin, which is a really old first generation cephalosporin. Keflex has the CEPH prefix. Really, almost all of them have a CEF prefix. Penicillins have a -cillin suffix on them. The carbapenems have the -apenem suffix on it. The aminoglycosides will have a mycin with an I or a mycin with a Y suffix on them. And those are just a few examples of that. And what about the principles of antimicrobial therapy? And the antimicrobial choice is based on coverage for the most likely causative pathogens, risk for resistance, and best evidence. So when we're talking about uncomplicated UTI, very, very, very high risk of a gram-negative organism, quite low risk of a gram-positive organism. So let's cut to the chase and go over acute uncomplicated UTI, cystitis and urethritis in non-pregnant women. So what bug rules the roost here? You probably all know this, but good to remind your students. E. coli. Gram-negative rod, most common pathogen. It's 75% of all UTIs. Klebsiella species is also gram-neg. And then there's this little sliver of UTIs caused by a gram-positive organism, Staph saprophyticus. And Staph saprophyticus is most often found in UTI in younger females, like teens, 20s, and actually has a very high correlation with the use of spermicides. And the thought behind that, of the use of the spermicides, is the use of the spermicides actually alters the protective flora in the lower reproductive tract, in the periurethral area in the female, and therefore puts them at higher risk for colonization with Staph saprophyticus. Okay. And so this is when it gets into you need to have access to an antibiogram. And your antibiogram, you can access this from either your whatever lab you send your cultures off to. If you're part of a larger healthcare system, ask your pharmacy and therapeutics committees to supply this for you, or your local Department of Public Health. So a whole bunch of different places you can get the antibiogram. And the primary recommendation, and this comes from Sanford Guide, if the local E. coli resistance rate to trimethoprim sulfamethoxazole is less than 20% and no allergy, then go ahead and use Bactrim, trimethoprim sulfamethoxazole. Make sure it's the DS. DS actually stands for double strength, POBID for 3 days. All right. So before we go any further, There is not a corner of this nation where the local E. coli resistance rate to trimethoprim sulfamethoxazole is less than 20%. There really isn't. There are parts of the country where the local E. coli resistance rate to Bactrim is 40%. And some certain communities, it might be approaching 50%. And so this remains one of the recommendations, but there's hardly any place in the nation where this would be effective. And let me just make a comment about the trimethoprim sulfamethoxazole, the DS part of this. What happened 30 plus years ago when E. coli was quite consistently sensitive to Bactrim, quite consistently, there started to be the notation of an increasing number of treatment failures. So what was being used back then was what today would be called single strength Bactrim. And what happened was the dose of both of these drugs were doubled. And now the E. coli could be effectively eradicated with this. But starting probably about 10, 15 years ago, there were rising rates of E. coli resistance to Bactrim. So what's the alternative then? If the local E. coli resistance rate to trimethoprim sulfamethoxazole is greater than 20% or sulfa allergy, go with nitrofurantoin. Macrobid is the trade name, 100 milligrams POPID for 5 days. And make sure you add pyridium. Pyridium is a dye that turns the orange brilliantly. Pyridium is a dye that turns the urine brilliantly orange, and it does not have any antibacterial activity on its own, but it is brilliant, brilliant at symptom control. And what it helps to do is prevent callback from patients that's unnecessary. Now, I don't want to make it sound like I'm saying, oh, those patients are such pains and they call us back all the time. But like, let's say that you have a person who is on taking nitrofurantoin for the treatment of a UTI, is on like day 3 of therapy, and it still kind of burns a little bit when she urinates. It does. It's not 100% yet. But the urinary frequency is better. There's no fever. There's no foul smell to the urine. What often happens is the practice will get a message, a call, or whatever, saying, you know, I'm on that 3rd day of the macrobid. There's only 2 days more, and it still hurts a little bit to pee. And what a lot of well-meaning providers will do is say, oh, then let me give you a week of ciprofloxacin. You must have had treatment failure. When what it is this is the way I always describe a UTI to a person when they've got them. I said, imagine if you could look inside your bladder and your urethra, the little tube where your urine comes out. It would look a little bit like a scraped knee. Everybody knows what a scraped knee looks like because everybody in their lifespan, one time or another, has fallen and scraped their knee, right? And I said, and you know how like a scraped knee is just really, really kind of red raw? That's what the inside of your bladder looks like. It's going to take a while to heal. And it won't take too long. It heals up pretty quickly within a number of days. But in the meantime, take the pyridium so that you're more comfortable. And I've had women come back and who had seen me for UTIs, and I put them on pyridium and said, I've had 5 UTIs in the past 20 years. So it's not frequent UTIs, but I've had 5 UTIs in the past 20 years. You're the first person that gave me pyridium. That's like a miracle, isn't it? And I said, yeah, it really is like a miracle, because as soon as the dye starts going through the urinary tract with that next void, literally the next void, when that dyed urine goes over the urethra, almost all the pain is gone. It really is quite remarkable. Now, one of the things is get your urine culture before, in your UA, in your culture before, the peridium is on board, because a dip urine is useless once peridium's on board, because it stains the dip. It makes all of the little dip measures orange. Every single one of them is orange. They're all the same color orange. You can't get any data out of it. The culture will be unaffected by it, but of course you're going to get the urine dip before you prescribe any meds. So anyway, all right. So this is your antibiogram. Hopefully this is full page on the end of your handout, because if you're just looking at this in a wee little image, like, 6 slides in a handout, you're in one page in a handout, you're not going to be able to read this. But what I want to point out to you here in the antibiogram is, see, the beginning is gram-positive organisms, and then it goes over to gram-negative organisms. The first gram-negative organism is E. coli. And you'll see the number of isolates from this lab. There were 246 isolates. And yet, if I send you over and tell you to look at just a few others, there were only 15 isolates tested. So why so darn many isolates of E. coli? It's because they pretty much all came from urine cultures, and we always do a urine culture, okay? Strep pneumo, that might be a pneumonia. We just don't do that many outpatient sputum cultures, all right? So when you go down there, when you follow it down and it says ampicillin 47, that means 47% of the isolates are sensitive to ampicillin, which then also means they would be sensitive to amoxicillin. That's unacceptable. That would be a greater than 50% failure rate, okay? And then if you go down and look at, I'm going to skip over the numbers that are really, really low. Piperacillin and tazobactam, that's parenteral. So that really doesn't have much to do with what we're talking about here. But when you go down a couple more, you'll see cefalozin there. It might be another parenteral antibiotic. I'm pretty sure it's parenteral, but about almost 90% of the isolates are sensitive. That would tell me that second or third generation PO cephalosporins would also be effective against UTI in this community. Ceftriaxone, 97% effective. And if you're saying, yeah, but we're not going to go around treating a simple cystitis with IM ceftriaxone. Well, cefpodoxime, ceftriaxone, same difference. Cefpodoxime is PO, so that's great. Now we're going to go down. We're going to notice after a bunch of cephalosporins, there are a bunch of empty cells. And what that means is those antibiotics were not tested against E. coli, because those are antibiotics typically not used to treat UTIs. And then when we get down to tetracycline, which would mean the same with doxycycline, the most commonly used tetracycline form around, 69% of the isolates are sensitive. That's too much of a failure rate. And then we're going to go down to below that, and we'll see levofloxacin, 62%. So that's even worse than the tetracycline. And if we've got only 62% of the isolates of E. coli in this community sensitive to levofloxacin, that also means it's the same probably for ciprofloxacin. Let's go down, and ciprofloxacin, it's a little bit better at 69%. Okay, but now let's cut to the chase and get down to Bactrim. Trimethoprim sulfamethoxazole. 66% of the isolates in this community are sensitive. That means 34% are resistant. This is not a community that you would use Bactrim in. It's not. All right, and then going down there, do you notice with nitrofurantoin, 96% of the isolates are sensitive. So that's almost like a home run, almost a guarantee that this is going to be effective. And then when you go down there, there are some other antibiotics like amikacin, an expensive old school parenteral only antibiotic, really is not germane to what we're talking about here. Meropenem, 100% of the isolates are sensitive. That is sometimes used in complicated UTIs. So what are the alternatives if there's a reason not to use a product such as nitrofurantoin? The alternatives are fosfomycin, ciprofloxacin in its immediate release and extended release form, levofloxacin. One more time, though, I would be a little bit hesitant to prescribe that in this particular community because I know there are a good deal of E. coli that are resistant to the fluoroquinolone. Amox with clav can be used. It's not my favorite. And then you'll see that there is a couple of notation of cefdinir and cephalexin. And so the cephalosporins can be really helpful in the treatment of UTIs when there's a reason why you wouldn't want to use nitrofurantoin. And if you're thinking, well, when wouldn't you want to use nitrofurantoin? G6PD deficiency, because it could cause that person to hemolyze. And a lot of times during pregnancy, we go to the cephalosporins because they've been used for literally 40 years during pregnancy. And observational data says that they are helpful and also safe to use during pregnancy. So there are the alternatives going on there. Now, remember, a lot of these are only 3 days of therapy, but some are upwards to 7 days of therapy, like with cephalexin. Cefdinir, if I use a cephalosporin, a lot of times in a UTI, a lot of times I do 3 days of cefprozil. It's like cefdinir's best friend. It really is. And it works, and it's FDA approved for the use in UTI. Now, here's something disturbing that I heard from somebody not too long ago, and that ciprofloxacin, a 20 tablets, the prescription costs as much as 6 tablets, okay? So 20 costs as many as 6. And if you were prescribing the standard immediate release ciprofloxacin, 250 milligrams POBID for 3 days, you only need 6 tablets, right? And I heard that there are some practices, particularly when they have patients who income is an issue with them and they don't have insurance or something along those lines, pay is higher than like $4, which many people have. You can get on the $4 drug list, you can get 20 ciprofloxacin tablets for $4. You can get 6 ciprofloxacin tablets for $4. And that there are some well-meaning providers that are prescribing the 20 and not just the 6, so that in case they get another UTI, they can use it over again, or they might as well get their money's worth. No, please don't do that. That's a terrible, terrible, terrible idea, okay? So why these, I could see a question came in. Let me just get through this part and then I'll answer the question. So why these particular antimicrobials? Nitrofurantoin is preferred and has been preferred for a number of years now due to the low risk for resistance. It's been available for decades, but why didn't anyone use it? Until about 2010, this was an expensive branded antibiotic. Now, yes, I'm very well aware 2010 was 15 years ago, seldom used, but a lot of times when really pricey drugs finally have their, they go generic and their price starts to come down, it takes the marketplace 5 to 10 years to figure out that they're not expensive anymore. Like I'll have people tell me all the time, oh, I wouldn't possibly prescribe rosuvastatin as a statin. Happens to be my favorite statin. It's way too expensive. Well, that was true 10 years ago. And it's a little bit more expensive than atorvastatin now, but not much. It's only a few bucks a month more. Now, fosfomycin, Monural, is a drug that very few providers know anything about. It is a single dose option for the treatment of a UTI. Mix it in water, slug down one dose, and it hangs around for a long period of time, which is why it's one dose. Generally very well tolerated too, but it's $30 a dose. It's been generic for a while, it's quite safe to use, been generic for a while, but generic drugs don't come down in price unless the world is clamoring for them, and therefore a bunch of generic manufacturers get in the mix. I've even heard from providers that their local pharmacy doesn't even carry fosfomycin. And it's an antibiotic. You can't wait 2-3 days for it to be shipped in. And then levo and ciprofloxacin were moved from first line a number of years ago due to the growing concern for resistance. So here are a couple of little pharmacokinetic lessons to do with your students. Nitrofurantoin is only indicated for uncomplicated UTIs. Only FDA approved indication. It's not even approved for pyelonephritis or upper UTI. Why is that? It is only concentrated in the urinary tract. It is not even concentrated in the renal pelvis that well, all right? But levofloxacin, when you look at it, it has FDA-approved indications for complicated, uncomplicated UTI, pneumonia, skin and soft tissue infection, select STIs, and a number of other things. Why? Because levofloxacin is widely distributed through body tissue. And it's important to remember that there are some antimicrobials that have a laundry list of indication, and then others like nitrofurantoin, it does what it does, that's it. Right? So let me answer the question or questions that came in. For UTI, would you treat empirically without a culture? And if so, what would you use? You know what? I wouldn't treat without obtaining the culture. And general rule, what we do where I practice is we get, if the chief complaint is dysuria, the MAs will have pee in a sterile cup, okay? They'll do the urine dip, bring the results back to me. 100% negative, and this isn't a UTI, maybe it's chlamydia, maybe it's gonorrhea, I have to start looking at something else. We just discard the urine specimen. But if it does dip, then positive for leukocytes or WBCs, which are actually neutrophils, indicative of bacterial infection, particularly positive for nitrites, that should make you think gram-negative UTI, because what the bacteria in the bladder does is it reduces dietary nitrates to nitrites, or is it the other way? Positive for nitrates. Okay, so it takes it in the urine. We've got the urine already obtained, and one of the things is I'm nothing if not pragmatic, and I practice in a low-income community, and a lot of times people will say I don't want lab tests done. But one of the tough things is if you went right ahead and treated empirically without the urine culture, if there's treatment failure, you're between a rock and a hard place of where to go next. However, if it was back against the wall and I had to do that, I would definitely go along with nitrofurantoin as my first line for a younger, healthier adult. Another question, best for UTI in a person with low GFR, cephalosporin. And one of the things I would say with this is the following. You know, you get that older adult that comes in who's got for a sick visit and they've got, quote, a little bit of kidney trouble, but you don't know what it is, and maybe you don't have access to their GFR or their record or whatever. One of my rules in prescribing antibiotics is it's really hard to hurt somebody with a cephalosporin. And I mean that. It's very hard to hurt anyone with a cephalosporin. You can use them down to GFRs in like stage 5, CKD. You really can. They're quite safe. Can you discuss fosfomycin more? Can we use this in older adults with renal impairment? Yes, you can. Can I rattle off the dose adjustment off the top of my head? No, I apologize. I can't, but there is adjusted dosing there for people with lower GFRs. What are your thoughts on boxed warning with the quinolones and the QT drug interactions with many medications? Is it not significant and that the dose is only 3 days, or would I stay away from the quinolones because of that? One more time, it depends. If for whatever reason I was going to go with 3 days fluoxetine for a UTI for a 25-year-old with no cardiovascular disease, I am not one iota worried about that person prolonging their QT interval and ending up with torsades or Runavitac or something like that. I'm really not, particularly if that person's not on any other meds. Okay. But I've got an 80-year-old who I know has some underlying cardiovascular disease or a high degree of suspicion for some structural abnormality in the heart, like LVH, which puts somebody at really, really high risk for sudden cardiac death. And I had to use an antibiotic, and I'll limit my comments to UTIs, and I had to prescribe an antibiotic for that person. I would really steer clear of the fluoroquinolones because of the QT prolongation that goes along with this. The other thing is more tendon rupture in the older adults with the fluoroquinolones, because the older we get, the thinner the tendons get, the more easily they rupture. And one more time, I'd go to a cephalosporin. That's my go-to drug. It's my go-to drug class when it comes to COPD exacerbation and UTI. So Beer's criteria, true or false? There is evidence of vaginal estrogen for the treatment of vaginal dryness and UTI prevention is safe and effective in women with breast cancer, particularly at doses where the systemic estradiol dose is less than 25 micrograms twice weekly, which is where it would be with using vaginal estrogen a couple of times a week. True or false? And that is absolutely positively true. So how does that help prevent UTIs? The way it does is it allows a recolonization of lactobacilli around the periurethral area that then keeps pathogenic organisms in check. Now, what about extended spectrum beta-lactamase producing E. coli? What are the risk factors for acquisition according to the Sanford Guide? History of repeated UTIs, recent inpatient healthcare facility stay for greater than 3 days, obstructive uropathy, BPH, and others, recent fluoroquinolone or beta-lactam exposure. So the use of afloxacin, one of the penicillin family, or a cephalosporin within the last 3 months. Why would that be? Because that messes up normal. And travel to Asia, the Middle East, or Africa within the past 3 months, where there is a risk of action of beta-lactamase producing, extended beta-lactamase producing E. coli. And so which of the following is the strongest risk factor for extended spectrum beta-lactamase UTI in rank order? History of repeated UTIs, presence of urinary catheter, prior antibiotic exposure. So we're going to go from 1 to 3. 1 is prior antibiotic exposure. This gets back to what I started off with, saying we have to keep in mind that we can't just be throwing antibiotics around at people who don't need them, all right? Then number 2 is presence of repeated UTI, a history of repeated UTIs. Number 3 is presence of urinary catheter. Isn't that unbelievable? And what do we always tend to think of is people who have an indwelling urinary catheter have super high risk of UTIs, which they do. But a lot of times what it is they get colonized really early on. So extended spectrum beta-lactamase producing organisms, what usually works? Nitrofurantoin, fosfomycin, and who's most likely to get these ESBL producing organisms? Older adults. So it's good to keep that in mind with nitrofurantoin. And then this, you look at this and you go, what the heck is this? Amox with clav plus ceftonir. Say what? Why those two antibiotics? Which I would not do this because this would be so tough on the gut. You're actually giving the amox with clav, the augmentin, for the clavulanate part only, because clavulanate will neutralize the beta-lactamase being produced by the bugs and allow the ceftonir to work, okay? And then intrapenem is often used if an IV antimicrobial is needed. So what about asymptomatic bacteriuria, according to the Infectious Disease Society of America? In the absence of UTI symptoms, it would be a clean catch voided specimen with the isolate of the same organism in quantitative counts of equal to or greater than 10 to the fifth power colony forming units. In men, one specimen, you've got your diagnosis. In women, two consecutive specimens. In a person who has been catheterized, and remember, asymptomatic bacteriuria, always in the absence of UTI symptoms. And in a person who's been catheterized, a single catheterized speck with a much lower colony count is considered adequate. So how often do we see this? In healthy premenopausal women, it's about 1 to 5%. During pregnancy, it goes as high as 9.5%. Postmenopausal women age 50 to 70, as high as 8.6%. Women with diabetes, it can be as high as 27%. Men with diabetes, 0.7 to 1%. Men just, their plumbing is different than females, and they don't get UTIs as often. An older community dwelling adult, greater than 15% of women 65 years and older, and about 3 to 19% of men age 65 years and older. So what are some risk factors for having asymptomatic bacteriuria, with the exception of pregnancy? Fecal impaction, and medications that encourage constipation, urinary retention, such as anything with an anticholinergic effect. The anatomic variations like cystocele and BPH, hygienic issues, it could be fecal soiling, poor perineal hygiene, neurologic impairment impacting mobility and bladder emptying, and then postmenopausal hormonal changes that I talked about just a couple of minutes ago. So according to the Infectious Disease Society of America, this is what they have to say. One of the reasons I'm bringing up asymptomatic bacteriuria is the take-home message is don't treat it unless it's pregnancy, during pregnancy, or unless the bladder is going to be instrumented. Those are the only two times you should treat it. But what often happens is an older adult gets a urine culture, a UA done for whatever reason. WBC's in it, it gets reflexed to a urine culture, and this person had no UTI type symptoms, okay? But now they grew out bacteria, and a healthcare provider feels obligated to treat them, all right? And this is what IDSA has to say about asymptomatic bacteriuria. In older patients with functional and/or cognitive impairment with bacteriuria, so bacteria growing in the urine, and delirium, the acute mental status change, and without local GU symptoms or other systemic signs of infection, like fever or hemodynamic instability, we recommend assessment for other causes and careful observation rather than antimicrobial therapy. So even with nuanced cognitive changes, even though so often it is UTI, if there are no symptoms through the urinary tract, like new onset wetting or dysuria, something like that, don't automatically think the bacteria growing in the urine is the culprit. And so I guess this was so important, I think I put it in here twice. So when do we screen and treat for asymptomatic bacteria? As I mentioned, during pregnancy, because bacteria is associated with increased risk for preterm birth, low birth weight, perinatal mortality, and pyelonephritis. What happens during pregnancy is the renal pelvis dilates because of the increased circulating volume. That's normal during pregnancy. And so there's more reflux of urine from the bladder back up into the kidney. You treat for 3 to 7 days, depending on the antibiotic used. And antibiotic choice is dictated by the sensitivity of the organism. Easy enough. We typically then screen a number of times more during pregnancy. And so the other that I mentioned briefly, if there's bladder instrumentation or surgery planned where there's a risk of mucosal bleeding, generally that's treated with a week of a fluoroquinolone. But one more time, if there's bladder instrumentation being done, urology is going to be involved. I'll always defer to them on that one. And unneeded treatment can facilitate resistant organism development. All right, so let me see. Another question has come in. Are there PowerPoints to download? I don't see them. And Stephanie, can you give us the answer to that? So that's a Stephanie question, but I believe there are. All right, skin and soft tissue infection. Let's move on and wrap up with this. Now, a lot of times, once you start saying skin infection, everybody goes to like, oh, it's going to be staph. Well, it often is staph, but particularly out in the community, it's often strep as well. Now, one of the things, just as a reminder, these are both gram-positive organisms. Staphylococcus species, bullous impetigo, furniculosis, boils, skin abscess, necrotizing fasciitis, and scalded skin syndrome. Obviously, the latter two are less common. The Streptococcus species, Streptococcus impetigo, erysipelas, which is a superficial cellulitis that involves the face and the extremities, and necrotizing fasciitis can be part of that there. So let's take a quick walk through impetigo here. In clinical presentation, this is non-bullous impetigo. And you might look at this image here and go, what the heck is going on? This was a young man who was in a shower that was used by a bunch of other people. And he needed a razor because he wanted to tidy up the back of his neck. And he just picked up the razor that was sitting there. And it was a little on the dull side, and it scraped up his skin, plus it deposited a bunch of bacteria in there. So this is what, yes, adults can get impetigo. You get erythematous macule that rapidly evolves into a pustule, ruptures, then the contents dry, leaving a honey custard colored exudate. Yeah, it is more common in kids, but adults can get this as well. So this is what non-bullous impetigo looks like. Bullous impetigo, and this is, we're looking at the abdomen of a younger child here, is when there's blistering that goes along with the impetigo. In the bulla, or the big vesicles, contain clear yellow fluid that turns cloudy, dark yellow. The bulla rupture easily in about 1 to 3 days, and then they leave these little sore areas, kind of denuded areas that then crust over. And one of the things is you can look at this and say, ooh, that almost looks like this little squirt was burned with a cigarette. One of the things with bullous impetigo, if you take your obviously gloved hand, gloved finger, and press on it, the kids don't seem that bothered by it. They don't. Where obviously if this was a burn and you pressed on the burn, the child would cry, because you see this mostly in preverbal children, okay? This is what bullous impetigo looks like. So likely causative organisms are staph and strep. Non-bullous impetigo, a lot of times what we can do is treat with a local antibiotic like mupirocin, Bactriban, but not an over-the-counter topical antibiotic, not at all. You do need the prescription strength product like Bactriban. And it requires systemic antimicrobial therapy when it's extensive or if topical treatment fails. That young man with all that impetigo in the back of his neck, he's on the cusp of whether a topical will actually work on him. Bullous impetigo, because there are tons of lesions usually with it, usually systemic antibiotic is needed. Now, cellulitis, clinical presentation, and this is infection of the dermis and subcutaneous fat, usually caused by heat, redness, discomfort. Now, remember, this is not cellulitis that goes along with an infiltrated IV or something like that. This is cellulitis that occurs out in the community. Usually it's strep pyogenes, less commonly Staph aureus. Now remember, Staph aureus can occur in two flavors, if you will. There's MSSA, methicillin susceptible Staph aureus, which means that the mechanism of resistance, again, is beta-lactamase production. And methicillin is an old school penicillin that's stable in the presence of beta-lactamase. Or MRSA, MRSA, methicillin resistant, where the resistance is due to altered protein binding sites on the surface of the bacteria, obviously requires systemic antimicrobial therapy. Now, cutaneous abscess, I promise I'm going to get to the antibiotics for these in a moment. And this is, remember what an abscess is. It usually is a skin infection involving a hair follicle and surrounding tissue. Again, red, heatness, discomfort, we all know what they look like. Usually an abscess is staph, and it can be MRSA or MSSA, right? So when we look here, we're back to the antibiogram, and what we're going to look at here and this community, and we're going to notice that it says Staph aureus on the antibiogram and now MRSA. You'll see that there were a lot of isolates of these two bugs. Why? Because there were wounds that were cultured, all right? And what's the difference between MRSA and the regular Staph aureus? They're teasing that out as something separate from MRSA. So here, when you look at this, you'll notice that 25% of the isolates of the first staph listed here are susceptible to penicillin and amoxicillin, or ampicillin. Ampicillin, amoxicillin, same difference. That means 75% of these isolates produce beta-lactamase. 75%. When we go to oxacillin, an old school penicillin stable in the presence of beta-lactamase, 100% of the isolates are sensitive. So that backs up the fact that you've got a mix in this community of beta-lactamase producing Staph aureus and then MRSA. So now what we're going to do is we're going to go over here to the MRSA. 0% of the isolates sensitive to penicillin, 0% of the isolates sensitive to oxacillin. So let's go down here a little bit more. And rifampin, remember, never, ever, ever use rifampin as monotherapy in suspected staph infections because it's going to develop resistance really, really quickly. On this side with the MSSA, methicillin sensitive, 1% of the isolates are sensitive to a cephalosporin. That's great. Why weren't more cephalosporins tested? Because if it's sensitive to one, it's going to be sensitive to the class. Now we get down to Vanco. Vanco works with either. Linezolid works with either. Obviously, Vanco is parenteral only. So there's that. Linezolid is PO and IV, but it's very, very expensive, so it's not used as a first-line drug. And then when you get down here, what else will we see? Tetracycline, 97% of the MSSA is sensitive to that. That means it would be sensitive to doxy. 91% of the MRSA is sensitive, so that's pretty good. The levofloxacin against the MRSA looks miserable, doesn't it? 75% of the isolates are resistant. Now, Bactrim, 99%. with either one. Yay, yay. So we've got a couple of good PO options here, regardless of whether it's MSSA or MRSA. We've got a tetracycline form, so doxy, plus we've got Bactrim. So we've got, in this community, we've got two different ways of looking at this, right? So when we look at this, I'm going to start over on the left with the cellulitis erysipelas in impetigo. And when I'm teaching this, I always focus on the mild side because of the fact that what I have to do is work with people and get their heads out of the acute care hospital so that they're really looking at PO antibiotics. And when systemic therapy is needed, it can go with PO penicillin or, and remember, cellulitis erysipelas, impetigo, most often strep, sometimes staph, but most often strep. So plain old penicillin or PO cephalexin or PO diclox or PO Clinda, right? So how do you respond to a student that says, okay, which one do I prescribe? Well, let's think it through. Let's say there is a mix of beta-lactamase producing and non-beta-lactamase producing bugs somehow or another in the mix. You prescribe penicillin, the beta-lactamase will do its thing and chop the penicillin up, but it won't chop the cephalexin up. Cephalexin, it's cheap, it's on the $4 drug list, very easy on the stomach, 0.0 drug interactions, great choice. That's what I would go with. Now, dicloxacillin, old school penicillin, stable in the presence of beta-lactamase. It's more expensive than cephalexin. It's multiple doses a day, and it's actually hard to get your hands on it because not many people prescribe it anymore. So it's a perfectly fine choice, but cephalexin is easier to live with. Clindamycin, the oral antibiotic most often associated with C. diff out in the community, not a fan, not a fan. And then for topical, for non-bullous impetigo only, upiricin. Okay, now abscess. One of the things these guidelines don't do a great job on is defining mild to moderate abscess. Other than moderate, there's usually a big ring of red around it. And I find that's more common than just a simple little abscess with no red around it, because you know what patients do to these. They squeeze the dickens out of them trying to get them to open. And then they finally come in to see us. They bang up the tissue around it. There's a lot going on there. So what you do is an IND, always, 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 always the IND, and then culture and sensitivity. Start with empiric antimicrobial therapy with Bactrim or Doxy. And if you need to, adjust therapy accordingly, directed by the culture and sensitivity results. If it cultures out MRSA, you're going to stick with the Bactrim or the Doxy. If it's MSSA, you could switch over to diclox or cephalexin. And this explains why in some urgent care settings, or emergency rooms, when it is predicted to be hard to track a patient down, that patients with moderate abscess will have an IND and they'd be double covered with like Bactrim and cephalexin. It is to make sure that you'll cover both bugs. Now, going back to the antibiogram, doesn't look like that's necessary, does it? But then some people will say, yeah, but maybe there's some strep in the mix and the cephalexin will cover that better than the Bactrim or the Doxy. That's a point. That's a point, but that's the rationale behind that. So which to use, PO penicillin, beta-lactamase stable or not? Not. PO cephalexin, beta-lactamase stable or not? Stable. Diclox, stable or not? Stable, but QID dosing, pain in the neck. Don't ever set anyone up for failure with 4 times a day antibiotic. It's just too hard to take. Clinda, beta-lactamase stable or not? Stable, but the C. diff risk. Okay. So quick little drill. I apologize. I know I'm going over here, but I find people love this drill. So we've got amox, trimethoprim, sulfamethoxazole, ceftriaxone, and moxifloxacin. Avoid use with ACE inhibitor or ARB due to hyperkalemia risk, particularly with CKD or volume depletion. And which one's that? And that's Bactrim, because the trimethoprim part is mildly penicillin. I'm sorry, the trimethoprim part is mildly potassium sparing. Vulnerable to destruction by beta-lactamase. Oh, I think I've put that forward enough tonight. That's amoxicillin. Use is associated with tendon rupture risk, particularly when used with a systemic corticosteroid. And that is going to be moxifloxacin, and less than 1% cross risk in penicillin allergy. And that is going to be ceftriaxone. That's for all of the cephalosporins. And then the beta-lactams, the penicillins and the cephalosporins, doxycycline and the macrolides. Drug of choice for mycoplasma infection due to rising rates of resistance with the macrolides. And that's doxycycline. Pneumonia has been a big thing the last couple of years, particularly with younger adults. One of my teenage grandchildren had it a couple of years ago. Ineffective against the atypical pathogens like M. pneumoniae and C. pneumoniae. The beta-lactams. Doxycycline works against the atypical pathogens. The fluoroquinolones work against it, but not the beta-lactams. And use is associated with higher risk of cardiac arrhythmias. You want to consider an alternative in patients with underlying cardiovascular disease. And which one's that going to be? That'll be the macrolides. And the macrolides have azithromycin and clarithromycin have more QT prolonging potential than the fluoroquinolones actually do. Most of the fluoroquinolones that did a nasty job on QT prolongation have been removed from the market, and they were removed from the market a while ago. So you see a 36-year-old man with no chronic health problems who presents with two furuncles, each about 3 centimeters in diameter on the upper thigh on the right. They've been present for about 3 days, slightly increasing in size during this time. He's without fever or other systemic symptoms. And he's actually had repeated episodes of this. You've eliminated the possibility of underlying immunosuppression or diabetes. So what about MRSA decolonization according to IDSA? And I know a lot of times people are familiar with this from the acute care setting, but what they'll say is, does this play any kind of a role out in the community? And IDSA does advocate for this in select cases if there's recurrent skin and soft tissue infection, despite optimizing wound care and hygiene measures. Ongoing transmission occurs among household members or other close contacts, despite optimizing wound care and hygiene measures. And how would this be done? Where's the MRSA coming from? Probably the nose. And so mupirocin BID for 5 to 10 days, oral antimicrobial therapy only for active infection, not for decolonization. And the caveat on oral antibiotic use if topical decolonization is not effective and the organism is sensitive. The other thing is to use things like chlorhexidine baths for 5 to 14 days. The alternative can be dilute bleach baths, which would be a teaspoon of bleach, like Clorox, per gallon of water, or a quarter of a cup per a quarter of a tub of water, or 13 gallons of water, and bathing for 15 minutes twice a week. That can do a good job of decolonizing the skin as well. Okay. In conclusion, prescribe when needed, know the bug first, right med, right dose, right length of time, always hold off when not needed. So I want to thank you so much for your time and attention. And let's see if any other questions came in here. All right. Questions or comments? And I just want to thank you for being here with us. Thank you. Okay, there are no questions, no comments. Thanks again for joining us tonight and looking forward to working with you on future programs.